Go. So we asked everyone mute your microphones when you're not speaking. And this slide here explains how you can do that. So there's that arrow down there is on a mute button. You press that, the red line through it will indicate mute. And if you have any trouble hearing, you can expand that same button and choose a different microphone or speaker system. And if you have any trouble, also you can just message me in the chat and we'll see if we can help you out there as well. And we encourage engagement, so please feel free to use any of the reaction tools at the bottom. You can see it, see the chat there. We've got raise hand and some emojis as well. So please feel free to indulge yourself in them so we can have a nice and interactive conversation. And with that, I'll hand over to Dan Andrews.
Thank you so much, and welcome, Drew, to this team, and welcome everybody to the Hospital Systems Addiction Care Community Practice. I'm Dan Andrews. I work for the Foundation for Healthy Communities, and I'm the director of the Substance Use Disorder Treatment Project, and have the great pleasure of working together with Growth Partners and with the Bureau of Drug and Alcohol Services, who provides funding for all this work, to bring you these excellent presentations. Today we have a particularly excellent presentation. For any of us who have been around for a while in the substance use field, we have probably seen the reports from the medical examiner's office that Kim Fallon regularly sent out. And today we have the chance to meet the person behind all of that. Kim has recently retired from the medical examiner's office after 32 years of working there. And let me give you a little background on Kim. And I apologize, I'm a little slower. The 3 days before the annual meeting, our copier broke here at the Foundation, which is also the Hospital Association. So welcome, Kim. She began her career as a death investigator in the Chief Medical Examiner's office in 1993, and she was the Chief Forensic Investigator for the office from 2005 until her retirement last year. She was certified by the American Board of Medical Legal Death Investigators in 2009. Kim holds a Bachelor of Science degree in biology from Southern Connecticut State University, and she has also earned a master's degree in investigations from the University of New Haven. Prior to becoming the Chief Forensic Investigator, she was the Bioterrorism Surveillance Coordinator at the New Hampshire Department of Health and Human Services from 2001 until 2005. And let me rejoin you on screen there. And some of the things that Kim will be covering for us today include, if we can jump to the
oh, sorry,
objectives, no problem. I usually have these printed out, but how the medical examiner's office investigates deaths associated with drugs and the process used by the medical examiner to determine that the cause of death is drug-related. Kim, it is a pleasure to welcome you to this community practice, and I'll turn it over to you.
Okay, now I will start sharing. How's that? Can you see it? Yes, okay. So I'm going to talk about the medical examiner's office, and some of my objectives are understanding how death investigations are covered in New Hampshire, also understanding just what the Office of Chief Medical Examiner is, and how our forensic pathologists, who are our doctors that do the autopsies, how they determine the cause of deaths in deaths that are associated with drugs. And also, Dan was going to monitor the chat, so if anybody had any questions during it, just feel free to put it in the chat, and I will do my best to answer it. The Office of Chief Medical Examiner in New Hampshire was not founded until 1986. Other states, Maine and Massachusetts, had medical examiner offices. So if somebody needed an autopsy, they ended up getting either flown to Maine or transported down to Boston, usually for an autopsy. The ME's office is in the Department of Justice. Our scene investigators or death investigators are called ADMEs, for Assistant Deputy Medical Examiners. And most of them are either physician assistants, paramedics, or registered nurses. And until almost 2 years ago, they were independent contractors. Now they're full-timers. But independent contractors meant that they were not full or part-timers. They sent me their schedules, and I fit them in, you know, throughout the schedule. It wasn't the greatest system because we didn't have enough to cover everybody, but we switched to full-timers, which is also not the greatest because we still don't have enough people. But I'll explain that in a minute. So right now in the office, Dr. Jenny Duval is the chief medical examiner. Mitchell Weinberg is the deputy chief medical examiner, and Abby Alexander, who started a year ago in August, is the associate medical examiner. They're all board certified forensic pathologists. So they're trained in death investigations and what to look for on bodies in terms of injuries and other signs. I had the chief forensic investigator position. There's a deputy chief forensic investigator, and those are the two full-time people that work in the office. There's a part-time evidence tech and 2 administrative assistants. And the system that they switched to almost 2 years ago, it's 10 full-time ADMEs and 2 part-timers that cover the whole state 24/7. So there is a lot of stress on those people because there are a lot of cases, and there really could use some more ADMEs, but we're under a budget there. We are accredited by the National Association of Medical Examiners, which is also called NAME for the acronym, and they have standards including how many autopsies a forensic pathologist can do each year. And the ideal number is around 250. If you do more than 300, you can get dinged on your accreditation. So Dr. Duval, several years ago, she was up to 297 because we only had 2 forensic pathologists for so many years. And we've had to, in the past years before we got Abby Alexander, had to have forensic pathologists come from out of state to, you know, kind of fill in for several days or a week. And usually that happened about once a month, so that, you know, they didn't go above the standard for the number of autopsies they could do each year. But there's also standards for drug deaths, and they should be autopsied. And if you don't, if you're not accredited, Dr. Andrew had told me before they were accredited, which has been about close to 20 years, he would be testifying in court. He was our former chief medical examiner, and the defense attorney would bring up how the office was not accredited. So it's an important thing to have. Also just kind of a little learning point for all of you. New Hampshire has a medical examiner system, which is not synonymous with a coroner system. Coroners are elected, and they're not necessarily forensic pathologists. Actually, anybody could be a coroner. There are places where funeral directors are coroners. You know, somebody that works in the hardware store could be a coroner. It's just an elected position. And they do have doctors doing the autopsies, but they're not necessarily forensic pathologists. And according to the standards, most suspected drug deaths should be autopsied. There's a nationwide shortage of forensic pathologists, which is why we only had 2 for a long time. And to get the 3rd one, that was in the works for about 2 years. She was doing her fellowship and wanted to come to this area. So we had to wait that long to get her. And that was in August of 2024. So we do what they call investigating untimely deaths, and everybody has a different idea of what untimely deaths means. I've gotten calls from the police for, you know, somebody that was 99 years old that didn't wake up one morning, and the police would say it was an untimely. But we establish the cause and manner of death and release the remains to the family in a timely manner. This is the law that gives us the legal authority to investigate certain deaths, and it's not all deaths. We do not have jurisdiction over all deaths that occur in the state. There's 25 different categories in the law, but it's automatically an ME case when it's an accident, suicide, or homicide. Most of our cases are accidents, a little over half, and then after that, it's natural deaths. So if something looked like it was a threat to public health, that would be an ME case, deaths occurring in legal custody. Also, a lot of people don't have doctors, so they become ME cases because they need a death certificate. We only autopsy about 1/3 of the cases. The other 2/3 gets what we call an external exam. So somebody goes over the body head to toe and then will draw specimens for toxicology testing. And because of the nationwide shortage of forensic pathologists, when there should have been around 1,500 in the country and there were only about 400 or 500 working full time, it's just not possible to do autopsies on everybody, at least, in our state with the situation we had. So a lot of the drug deaths were getting the external exam and toxicology drawn. I'm going to show some scene pictures, but they're not to be redistributed, please. And this was one of my cases, and it's kind of typical what we were seeing. Most of our deaths are from fentanyl, and people would just fall right over and drop dead where they were when they were injecting. So this is a close-up of the table that he was on, and you can see there's that orange cap, that's the needle cap for an insulin needle, which is what they usually use. And in that bottle cap, the green bottle cap on the right, those are little cotton balls balled up, and they're used as filters, and I'm going to explain that in a minute. And this is the same person. He still had the syringe right in his hand. So we saw that so often with people just kind of dropping unresponsive after injecting. People also use tattoos to hide their puncture wounds, and sometimes it looks like they found a vein under a tattoo that they previously had, and other times it looks like they got a tattoo to cover up kind of the track marks that the constant injections were leaving. This was another scene, and it's kind of typical. People inject in their bathrooms. And, we do see syringes, and we like to try to figure out, was it used or not? And this one was obviously used. You can see there's even a little fluid at the bottom of the syringe. The needle's there, and it looks a little bent, but it could be the angle. And also the plunger is drawn out. So we have cases sometimes where there'll be a needle there and syringe, but it looks like it wasn't used at all. So that can kind of be confusing. And this is another typical scene. You can see the orange cap on the left from the insulin syringe. This is a close-up of the spoon. And what the addicts will do is put a little powder in the spoon and mix it with some water. And oftentimes they'll take those bottle caps that you see and they'll add a little water to that. And so they're kind of measuring out how much water from the bottle cap goes onto the spoon. And then they'll use a lighter underneath it to what they call cook it until it's all kind of dissolved. And then this is a filter that's right in with the mix that they're making. And what they'll do is they'll put the syringe through the cotton and then draw it up that way. And supposedly it, takes out any like chunk pieces that they're not going to be drawing up. The needles are really small anyhow, or some people think it filters out the impurities. This is another scene. The syringe is there on the left, and you can see the caps. That other white cap there is for the end of the plunger end of the syringe. And there's a spoon with the filter in it. The NA on the bottle, I've been told, stands for Narcotics Anonymous. So it looks like somebody was trying to quit doing drugs. And this is my only other slide of people that I have deceased. And it just gives a good example of how they just become unresponsive almost immediately. You could tell that he was sitting up on the bed and then just fell back after injecting. And she looked like she was standing in front of the bed and just fell face forward. And we'll have people like in front of bureaus with their drug paraphernalia or the bathroom, and they just drop after they inject. And mostly I'm talking about injecting, but people do snort also drugs. This was a scene where the decedent had custody of his children on the weekends, and they were all watching TV together, and then he went into the bathroom, and he did not come out after quite a while, and the kids are knocking on the door and trying to get the door open, and finally called their grandparents, who came over. The grandparents couldn't get the door open. They had to call the fire department, who had to go in through a window because his body was blocking the door. But this is what his sink looked like. He's got the syringe there. You can see 2 spoons, a lighter, and then he's got this, his little drug kit. So he's got a syringe in there, and he's got Q-tips, which they use for filters also. And some of those little baggies, that's where they have their drug supply, in those little baggies. It's powder. Here's another case where the guy dropped dead right in front. He's got the spoon, and then right under the lamp on the top right, you can see the filters. He used cigarette filters for filtering his drugs, and he's got the lighter there. And in the you can see sandwich bags top left. He looked like a dealer. This was inside his drawer. It's called a bindle. He had more of them. So they'll use different things, like little bag. They have tiny little baggies that they can use to put drugs in, or they'll buy sandwich bags and cut them off and put the drugs in a corner and then tie it off. He had cigarettes. I always looked in cigarette boxes, because you don't always find cigarettes. Mostly I just found what looked like marijuana joints. The police took custody of those things. But, you know, we had the whole kind of all the supplies he needed in the drawer. And then I found this in somebody's wallet, and you can see the decedent right there. That's his knee in the upper left and his hands up in the air. So he's in rigor, and he got rolled over because his hand wouldn't have stayed like that, you know, if he had died in that position. But he had his wallet in his pocket, and this was in his wallet, which is kind of a strange way to fold a $20 bill. And he had a little bindle inside his bill. So New Hampshire, in the 1990s, we had so few drug deaths, and this was, there were like 40 maybe a year. And this is a graph of the heroin deaths, and you can see the y-axis there. It got up to 100 one year, and then it just plummeted. And so when we had the drug deaths, it started, you know, started keeping track of it. Dr. Andrew did, our former chief medical examiner. There were around 40 per year in the 90s. Then it went up in the 2000s when people were getting addicted to prescription oxy. And then those prescriptions got cut, and a lot of people turned to heroin. And we thought that was a really big deal when we had 100 deaths. But then it plummeted because fentanyl came into the picture. And you can see the y-axis. This shows 350 fentanyl deaths in 2016, and you know, we went over 400 after that. So the only reason heroin went down was because the fentanyl skyrocketed, and it shows both of them together. But for years, people would still be saying somebody used heroin, or, you know, I'd go to a scene and the police were saying they were a heroin user, even though we had known for years the big problem was fentanyl. And, you know, we'd have like 5 or fewer heroin deaths a year. And this just shows how all of our overdose deaths were really driven by the opioids. So the light brown line on the bottom are the opioids. Oops, sorry. And then the total number of drug overdoses is the blue lines, and it just matches up perfectly with the opioids. This is just different ways that people take drugs. So transdermal are the patches, the fentanyl patches, and you know, before we started getting the illicit fentanyl, people did overdose on prescription fentanyl, and sometimes it was their prescription and sometimes it was not. Sometimes, you know, it was a drug user took or stole somebody's. I had one guy who stole his grandmother's patch, and it was chewed up in his mouth. You know, when I was examining, I found it, and you know, that was a fentanyl death. And people can take it orally or IV, but this is all prescription fentanyl. And what we see a lot is practically all the time is illicit fentanyl. I feel like over the past several years, I'd had a handful of prescription fentanyl cases. And, you know, one that I can think of off the top of my head was a suicide where somebody's mother had died, and they took the fentanyl patches and put about 6 patches on their body and died from that. But this is information on what constitutes a therapeutic dose, a toxic dose, and a fatal dose. And you can see there's an overlap there, because a therapeutic dose ranges from 0.3 to 10, I think it's nanograms per deciliter. Toxic goes from 3 to 20, and fatal goes from 3 to 210. So there's this overlap of between 3 to 10 can be therapeutic, and it can also be fatal for some people. So our doctors have to go through that, and they don't get a toxicology report and look at something and say, oh, this is, you know, 100, so they overdosed and died, but it was 99, it would be okay, because it's so dependent on the decedent. So they're looking at things like their height and weight and their drug history. And I'm sure you all know that people who have been in rehab and then they get out and they do okay for a while maybe, but then they go back to using drugs, and they try to go with the same amount that they had used before, and then they overdose and die because they've lost their tolerance to it. So there's a lot that goes into interpreting the toxicology report, which is something that the forensic pathologist does. And I wanted to go over 2 cases, which shows the importance of doing autopsies. This was a homeless female who was in her late 20s, and she did have a history of IV heroin use. She was confused, lethargic. She was having some shortness of breath, and somebody brought her to the emergency department, and she got there, and then she coded. They did, you know, code for a while, including giving her Narcan, but she was not resuscitated, so she becomes an ME case. Also, when I go over, like when I was talk about the manners of death, you know, and how many are accidents, by far most of our overdose deaths are accidents. Overdoses are not natural. I have had some cops call me, and in one case he described the whole scene, except he didn't mention the drugs, which were prescription drugs, and everything looked natural, he said. And I was about to hang up, and he said, yeah, you know, I said everything looked natural to him, and he's like, oh yeah, no problem. I'm sure it's natural, and that he did this on purpose. And I was like, what do you mean he did this on purpose? Well, it turned out the cops had been there before because he'd been threatening to kill himself. And sometimes people think that because it's not blood and guts, that it's a natural death, but it's not. Overdoses are never natural. We have a few that are suicides, but most by far are accidents. So this is this woman that was brought into the emergency department, and you can see she's got a puncture wound in her antecubital there. We would want to know if the hospital, so she, not EMS, because she didn't come in by ambulance, but if they did, we wouldn't want to read the EMS report, but we would be asking the ED staff and reading their report. Did they start an IV there? And when it is an ME case and we take jurisdiction, and most of the hospitals know this, that they should not be pulling any lines or the intubation tube out when we accept it as an ME case, but sometimes they do. And it looks like she had everything pulled out. So we'd want to know, did they start this IV themselves, or did they try to start an IV and it wasn't successful, which they should document if they do that, even if it's not successful? Or could this be an injection point for that the decedent used on herself? And this was on her other arm. They look kind of older. And she had this on her hand. So again, we would be trying to figure out, was this something that the hospital staff did or medical staff did? And that's just a close-up of it. So this is her heart at autopsy, and it's kind of filleted open. And what we're looking at here is, I think I can make a pointer. Do you see the pointer? Yes, okay. This is not supposed to look like this, especially here. This is bacteria growing on the valves. And here it is again. You can see better close-up. When I was a biology major, we did microbiology, and you would plate this bacteria on agar petri dishes, and you would see things growing like this. And so she actually did not overdose. Her cause of death was infective endocarditis, but she did have drugs in her system. If we didn't have the autopsy, it would have looked like an overdose. Fortunately, we did that one. And then this was a case where this was a woman in her 40s who also was an IV drug abuser. She's found in the driver's seat in her car. She'd pulled over a little bit to the side of the road. She had vomited, and then there was a question if there was drug paraphernalia in the car. The police did get in touch with her family, who did talk about the drug use. This is a picture of her in her car. She died in that position. And that was a little plastic bag that it looked like she could have had drugs in. It was kind of questionable whether or not that was it. So the autopsy findings were her toxicology. Postmortem just means after death, and of course that's the only time our office does that. It was positive for fentanyl and methadone, but you don't get the toxicology report till like weeks or even sometimes months after you've done the case. And you can't leave, we don't keep bodies for more than a couple of days usually, unless the family or nobody's making arrangements for them. But we release the bodies and we have the specimens, but it takes that long to get the toxicology report, and then it can take longer, especially when we only had 2 doctors, because our doctor has to take time for each of these cases to review the toxicology report. But the autopsy showed she had a ruptured cerebral aneurysm, so that's in her brain. So her cause of death had nothing to do with the fentanyl and methadone. It was a ruptured aneurysm, and manner of death was natural. If it was cocaine or methamphetamine, which are stimulants, that could have been a contributing factor to an aneurysm. But in this case, it was not. So that's the importance of doing autopsies. And then I have our last overdose update that the office sent out, and they're not doing so many anymore. I don't know if they've switched to quarterly or not, because the numbers have went way down last year. And also the Chief Forensic Investigator and Deputy Chief Forensic Investigator are out of the office pretty often, because they're also doing cases, because there are a lot of cases and just the 10 full-timers, as I had said. But I want to explain this. It's really confusing, and we've changed the drugs that we monitor. We used to monitor heroin all the time and not fentanyl. So we switched to fentanyl and dropped heroin from it because there were so few deaths. And then we ended up adding meth and cocaine because those numbers were going up a couple of years later. So the top row that says fentanyl alone, that's only fentanyl in their tox report. And alcohol is considered a drug, and we do include that in our drug updates. But in this case, there's no alcohol, there are no other drugs. And then the next one is fentanyl and methamphetamine, which there is fentanyl and meth in the drug report, and there could be other drugs also, but there's not cocaine because that's listed under the fentanyl and cocaine. And there could be other drugs also there, but there would not be methamphetamine in that one. And then the next line, fentanyl, meth, and cocaine, that's all 3 of those with or without other drugs. And then fentanyl with other drugs, except for meth and cocaine. Then methamphetamine, that's methamphetamine with or without other drugs, but you're not going to have fentanyl and cocaine in those. I know it's kind of confusing, but I've realized some people don't understand it, and other people understand it perfectly. And then cocaine, it's just cocaine or cocaine and other drugs, but not meth or fentanyl. And then the same with methamphetamine and cocaine. It could be other drugs with them, but not fentanyl. The other opioids and other drugs, the other opioids are mostly like oxycodone, morphine, hydrocodone, tramadol could be. Non-opioids are the benzodiazepines a lot. We've also seen things like Benadryl for suicides. The unknown drugs, that happens when somebody's been in the hospital and look like an overdose, and they're resuscitated, but they don't do well, and they ended up dying after a few days or several days or whatever. And the hospital has done a tox screen on them, which will come back something like unknown for opioids, or maybe the scene looks all like drugs, but the hospital didn't find anything. But the hospital doesn't have a great lab for doing toxicology testing. They're not set up for that, so they just generally do screens. But sometimes by the time we find somebody dies, they've already purged the admission specimen, which is what we want to see. We want to know what was in their system when the event happened. Same with a car accident. We don't really care what's in their system 4 days later or even hours later when they've been giving IV fluids and other drugs. And fentanyl is given as a pain drug, so we'll also have to, in those cases, look at the records and when we get the admission blood and see if they did get fentanyl administered. But that category for unknown drugs is when the admission specimen at the hospital has been purged and we don't have anything to test, but other things indicate that it was a drug death. And then the total confirmed drug deaths, right there, it's 149. Pending toxicology is just temporary. We have the body, we get the specimens from them, we send it off to a lab that specializes in postmortem toxicology testing. It's in Pennsylvania. And we wait to get the tox report from them, and then our doctor reviews it and determines whether or not the drugs contributed or caused the death. And this is, I just have a couple slides on manners of death. So the manners are natural, accident, suicide, and undetermined, and then also pending, which is just temporary. The by far, most of our deaths from drugs are accidental. People are using them for recreational purposes and don't intend to overdose on them. And then we have a few that are suicides. Often it's not fentanyl that it's somebody uses to take their own life. And then the undetermined is, and we can use that for anything, but in this case, it's because it can't be determined whether the death was accident or suicide. We have had some people that were drug addicts that have taken their own lives because they're pretty depressed because they're addicted to drugs. And if there's no clear indication, a lot of times our doctors will err on the side that's an accident, but if it's really unclear, they can put undetermined. And that can be changed at any time. You know, if 5 years later somebody's going through a drawer and finds like a suicide note from somebody that had died, and they bring it to our attention, and you know, we would check into it, and the police would probably check into it. You know, 5 years later, we can change the manner of death or even the cause of death. It's not set in stone. And then males to females, you know, it's almost like a 2-to-1 ratio, and that's for a lot of our cases. You know, car crashes and other suicides by, you know, hangings or gunshot wounds. It's often like a 2-to-1 ratio, males to females. But this is for overdoses. And then the ages, most of the overdose deaths, so fortunately there aren't any teenagers. Every once in a while we do have a teenager, but most of them are in like the 30 to 59-year-old age group. And you can see there's one in their 90s, and that person took their own life. So that was a suicide case. This was something that the DEA information that I got from them, from their website. So, you know, they were talking about, and this was within the past 6 months, it's a downward trend in fentanyl purity. So what they're talking about is there's still fentanyl out there, but the people that are supplying drugs are adding different things. It's still dangerous, but they're mixing the fentanyl with things like xylazine and other opioids. And so then they put out the statement that which results in people not knowing the exact composition of what they are consuming or selling, which is such a bizarre statement to me because people never knew what they were getting. You know, this is illicit fentanyl. It's not pharmaceutical fentanyl. There's no quality control. The distribution of the drug throughout, you know, the powder that they're getting, it's not equal. We've had cases where 2 people were doing drugs, one died and one barely got high from it. So it's just so strange that they would say people don't know what they're getting because fentanyl's being mixed when they really never knew what they were getting. And then you probably all know this, decline in drug overdose nationwide, and New Hampshire is fortunately following that trend. So it's attributed to the increase in Narcan distribution, increase in access to treatment, and then harm reduction, things like the fentanyl strips that people can get. And in some places they weren't even legal, and I think New Hampshire might have been one of them, but I think they are now. And then the opioid settlement funds, of which the medical examiner's office did not get any, but you know, that's been credited with helping people get into treatment. So this is my last slide. It just shows the prior to 2011, all the drug deaths were under 100 or under 200, sorry. And even after 2011, it just barely got to 200. You know, it was under 200 for a couple of years, and then how dramatically it increased in 2014. And then after that, until last year, it had always been over 400 and almost got to 500 a couple of times. Last year, it went to 287. I used to do projections when I put out the monthly updates, and I hadn't done them for the past several years because people just took it, you know, if it was like into June or July, I would start doing a projection, you know, how many drug deaths we were going to have a year. And it's based on a formula, and the formula includes the day of the year or the week of the year that it is, how many total drug deaths that were confirmed we had, and how many were pending toxicology. And you put that all in the formula and you come out with a number. And, you know, quite often it was pretty close, but there were a couple times when it was not, and people would get upset about that. And I was telling Dan yesterday, those doctors that we had filling in because we needed to keep our doctors' autopsy numbers over so much, they either had been told and didn't do it, or they weren't told, but they were supposed to put pending toxicology on the death certificate, so we would include it in that number. And one month we had 2 doctors filling in, and neither one of them put pending toxicology. So the projected number looked like it was going to be way lower than, you know, the previous years of drug deaths that we had. And then we kind of pretty quickly figured out what happened when we were looking into it, that they hadn't put toxicology, but I had already put the update out there. And I could hear on, you know, radio on my way home from work, people were taking credit for it, like why the drug deaths were going down, and politicians were taking credit. And then the next month I had to put out the revised number with the accurate projection. And I got calls from the governor's office. I got calls from the union leader and Keene Sentinel, and it was very, very stressful. So I stopped doing the projections. But you can always do the projections, you know, just with that formula, but you can't really rely on it. Some months you could, you know, not have a lot. It was hard to correlate when I was doing the drug data months. You know, one year you would have a ton of drug deaths in July, and then the next year you wouldn't have many at all. So it was hard to figure out, you know, what you couldn't count on any month. You're going to have a lot this month. You're not going to have a lot this month. But so I did do a projection for this year, and it looks like we'd even be lower than we were last year, but don't quote me on it, and I'll deny it that I said that. But the projection was around 250, which would be great. I mean, it's still 250 people that have died from drug overdoses, but so much less than it has been in the previous years. And that is that's my last slide. There's my contact information, and I didn't know if there were questions.
Thank you, Kim. Nothing has come in on the chat, so we'll just open it up for questions for Kim now. I'm delighted that Carol Furlong is here because, for one thing, she'll forgive me for identifying her, but Carol has had a longstanding role within the SUD treatment community of educating both external stakeholders and internally. And Carol has been on the Drug Overdose Fatality Review Commission for about 2 years and has come to the Data Task Force and other bodies, many other bodies, and talked about how this information gives us context that doesn't necessarily present with the numbers. And I'm particularly appreciative of the fact that you have created some context about accidental overdoses versus intentional and all that. And Carol, I'm wondering if anything kind of struck you from this presentation that with the wide range of organizations and different groups you're involved with, if this kind of stuff really resonates when we consume it ourselves and share it.
I would say that we have a representative on the opioid fatality committee from the medical examiner's office, and that information is always critically important. The opioid fatality commission is largely made up of legislators, state legislators, with representatives from various other organizations. We have a treatment, recovery, prevention representative, the public health departments are representative, police department. But we always, whenever we review cases, we always start with the medical examiner's information, and that sets the groundwork and really helps people understand the physical aspect of overdose, and not just overdose, but then that also provides a foundation for treatment providers to talk about how that client got there, the lack of resources for treatment. It's an incredibly important function. I've always said that the best part of that commission or attending that commission is watching the legislators really learn about addiction and all of the aspects of it. And those are open to the public if anyone is ever interested in going there. On the website, you can see when the meetings are. The second one is the PDMP. For those of you who don't know, the prescribed drug monitoring program is something that medical providers use all the time. When they prescribe something, they enter that information onto the PDMP, and then the state reviews that to see, for example, if someone is receiving multiple prescriptions of the same medication from various providers. If you don't have access, and you probably won't unless you're a prescriber, they are now considering giving permission for EMTs to have access to the PDMP, which just makes sense. But if you work closely with a doctor or a prescriber, a nurse practitioner, for example, ask them, make sure they're checking that. It's a great source of information. And again, it educates people. There's a great representation of various organizations, veterinary, pharmacy, medical professionals. It's critically important that we share this information. And I think as a treatment provider, and I'll speak for myself, I think that we as treatment providers have been negligent in not speaking with all of the other entities that are involved in a case. You know, as Kim said, think about all the different people that she referred to as being involved in cases. And we never speak to them. I'm concerned sometimes that we are siloed too much. If we're going to continue to address, as we have successfully, but if we're going to continually succeed at reducing the number of deaths and improving treatment, we really need to work together as a community. And that's why I'm so grateful that Dan brought Kim, because she's the medical examiner's office, and Kim's knowledge is critical to this.
While I would like to claim credit for this, I believe it was our planning group, of which you were a part, that said to us several months ago, we think having somebody from the medical examiner's office would be a great presentation for us. And I don't remember who made that. I think it might have been you. But yeah, there is certainly an interest in the work that Kim is doing. And speaking for myself, as someone who came out of the fire and emergency services industry and served for many years as a fire marshal, knowing the meticulousness that has to go into every investigation. And Kim, you have done so well today in showing some of the pieces of that and how rigorous that has to be before you can arrive at a determination. And I have an appreciation because people were always critical of our undetermined cases, and sometimes you just can't do it. And you have done an extraordinary job to shrink that number, but also to stand behind the data that you are presenting. So just as someone who has some fire/law enforcement background, that was a very, very interesting presentation.
Thank you.
Are there other questions? If there are not, we're well within time limits. And if nobody has anything else, I'd like to extend my appreciation to Kim for,
I think
go
there's
ahead,
a
Lauren.
question.
There, go ahead, Lauren.
Just really quickly, I wanted to say thank you. I did as well appreciate it. I work street outreach with the unhoused population, mental health and co-occurring. And when I saw the opportunity for this to come up, I wanted, so I found it very informational from your standpoint and from what you guys do. So I just wanted to say thank you. I did see that it was a small number of people that took advantage of it, but I think that if the opportunity is offered again, hopefully other people will take more advantage of it, because I think giving that education out to others to learn that, I was in the fire service myself. I was an EMT, so certain things didn't worry me in that aspect of things. But I think, as somebody else just mentioned, getting those other data points out and the things that you guys experience and investigate, I think that that's important. So I just wanted to say thank you. I really found it knowledgeable, and I think that it was a great opportunity. So thank you.
Thank you.
Thank you. Yeah, thanks for those great comments. Speaking about presentations and people availing of themselves, thanks to Growth Partners, we have a record of all of these presentations on their website, and that seems to be a good segue to turn things back over to Drew.
Just before I do that, Dan, I think Savitri had a question as well.
Oh, okay. It's okay. See it. Thank you, Savitri. I see that now.
Sorry about that. I just wanted to thank you, Kim, as well. That was really informative for me. I work with the City of Nashville Public Health, and just someone who works in prevention. It was really helpful to see that side of things, and gave me a lot of empathy for what you all go through. You know, seeing people in those conditions, even just me seeing the pictures, I was like, "Ooh, this is intense."
No.
Mm-hmm.
Yeah. So thank you.
All right, thanks, Savitri. So, as Dan just alluded to, you can visit nhtac.org to learn more about other COPs and view recordings of past sessions, as well as access the slides and related resources. And this session will be posted there shortly. And finally, we'd be very grateful if you could take a moment to complete this brief evaluation. Certificates and CEUs will be issued to those who complete the evaluation. The QR code is there, and I put a link in the chat as well, if that is easier for you. Other than that, thank you all very, very much. It's been a pleasure to be here with you, and hopefully we'll see you again soon.
Thank you.
Thank you. We probably have a few people with cameras on, but I don't mind saying this publicly. Kim, thank you so much.
Oh, you're welcome.
That was good. Good presentation, good energy, good knowledge, and am so grateful to have you there. And Carol, thank you for joining us too, and for being so tolerant of me, liberally tapping upon your experience and insight.